Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so glad you could be with us today. In my next segment, I'd like to discuss eyelids. In particular, one of the most common situations I see in the office, one of the most common complaints or common requests I see in my office as a plastic surgeon is when a person comes in and asks about the bags of the lower lid. That's one of the most common concerns I see as a plastic surgeon. Well, I want to talk a little bit about the anatomy of the lower eyelid, and then we'll talk about really what the bags are. Frequently, a person will come in and say, I'd like you to remove a lot of skin from my lower lid because this extra skin is causing this bag, and they don't like the appearance at all. We've got to be very careful when we remove lots of skin from the lower eyelid. And I'll talk about that in a minute. Now, key to any surgeon and any surgical procedure is to know the anatomy of the area. In other words, we need to understand the components that make up the structures, that make up the anatomy in that area before we effectively address it. I think for the eyelid, whether it's the upper eyelid or the lower eyelid, or any other structure of the face, for example, the neck, it is so key to do a careful individual analysis sitting down with the patient, because it can be a variety of problems affecting or bringing on a condition, and it's not just one cause, and it's certainly not one cure, because there can be many different causes for something like lower eyelid bags or so-called bags. As I said, most people will come in and they ask to have lots of eyelid skin be removed, but that's not always the right way to approach the issue. Now, to review some of the anatomy, if we look at the important layers of the lower eyelid, it's actually a very complex structure, but the important layers of the lower eyelid start with the skin. Of course, that's what we see, and the skin is very obvious to people. The skin can be affected by fine lines, fine wrinkles. It can be affected by pigment changes. It can be affected by dark circles, etc. But we need to start by examining the skin. We need to examine the quality of the skin, the color of the skin, if there's some extra skin, if there's a possibility that we can have a shortage of skin. And in general, that's how we start the evaluation of the lower lid. Now, just underneath the skin of the lower eyelid, there's a very thin layer of what we call adventitial tissue. Sometimes this adventitial tissue or connective tissue, it's almost like a spider's web. It's very thin and wispy. Sometimes it contains a very small amount of fat, but it's not the fat that we're so concerned with in the lower lid. Typically, the skin of the lower eyelid lays very closely to the muscle. The muscle is called the orbicularis oculi. That stands for, or I should say in Greek, means the orbicularis means orbit or circular. That's a muscle that goes all the way around, orbicularis oculi. It goes around or orbits the eye. There's also called the orbicularis oris. That's a circular muscle that goes around the mouth. So we have the orbicularis oris and we have the orbicularis oculi. So again, to review, the skin lies upon the very important orbicularis oculi muscle, and sometimes there's a very thin or wispy layer in between called adventitial tissue. Not so much deeper, but just under the orbicularis muscle is a very important structure called the orbital septum. The septum is a membrane. It's a very thin membrane like saran wrap. It's very thin, but it's very important. Now the membrane, the job of the orbital septum, the job of that membrane, in part is to support the lid, but one of its key components, one of the key functions is to hold the orbital fat in place. Now let's back up a moment. The globe or eyeball in everyone is cushioned and lubricated by lots of fat, and that's normal. That's called the orbital fat. It can be above the eyeball, there's a little bit on each side, and there's certainly plenty below the eyeball. Now, it's that fat that starts to push against the orbital septum or membrane that is primarily responsible for what most people call bags of the lower lid. Now, in certain families, that septum or membrane that I talked about, the orbital septum, in certain families, for some unknown reason, it tends to become weak, and it tends to become not so strong, and so it doesn't hold the orbital fat into place so well. And so some of that fat undergoes what we call pseudo-herniation, and it starts to protrude. Now, it doesn't really herniate through. You know, typically a hernia is a hole or an abnormally large opening in a structure of the body. And so a certain tissue can come through, like in the abdomen. You can have an abdominal or inguinal hernia where some of the gut can actually protrude through or pass through that hole. In the eyeball or in the lower lid, it's called pseudoherniation. It doesn't really protrude through a hole, but as that septum or membrane gets weak, the fat starts to push on that membrane, trying to sort of escape. But what it does is it gives the appearance of an excess fullness or bag. So that's primarily what people mean when they say, I notice these bags on my lower lids. It's primarily the fat. And we'll talk in a moment about how we address that. Now, there's another important structure that we have to look at when we examine the lower lid, and that's called the canthus, or the canthal mechanism. The canthus is actually a confluence of a tendinous structure. The muscle becomes actually thicker and tighter and becomes a tendon, and the tendon actually, or the lateral canthal tendon or mechanism, is in the corner of the eye closer to the ear. What that does is provide the proper elevation and strength for the lower lid. It actually suspends it almost like a hammock. It's attached to the bone, and that's called the lateral canthus, lateral canthal tendon, or lateral canthal mechanism. There's actually also one at the corner of the eye towards the nose. That's called the medial canthus, medial canthal tendon. That's affected, or we operate on that area far less frequently than the lateral canthal tendon, but it's also very important. Now, the reason why it's important to look at the lateral canthal mechanism, lateral canthal tendon, is because if that mechanism or that tendon gets weak, then the eyelid itself can droop even and give the sort of false appearance. It's almost like an optical illusion that there's a bag or there's excess tissue. It may not at all be that there's excess tissue, or it may be that there's far less pseudoherniated fat than you might think, but it's that the support mechanism of the lower eyelid is weak, and then it allows the position of the lower eyelid to slip down or fall down closer to the cheek. So that condition can lead to what we call excess scleral show. In other words, too much white showing under the dark part of the eyeball itself, under the pupil or under the cornea. That's called scleral show. Now, when that gets to be severe, that's called ectropion. That's when the lower lid falls down or gets so weak that it comes down or it gets pulled down by scar or some other pathologic condition. That's called ectropion. There's another condition called entropion, when the support system and the balance and the tone of the lid get out of balance and mismatched, and actually the eyelid can turn inward. And the eyelashes themselves can rub up against the eyeball, and you can imagine that that's a very painful, very distracting condition. And you can have trichiasis, where the actual eyelashes are irritating the cornea or the eyeball itself. Those two are medical conditions when you have ectropion or entropion. And when I say medical conditions, those are typically come under the category of a correction called a reconstructive surgery, so typically insurance companies can get involved. Now, if we're going to just do a cosmetic or aesthetic operation for the lower lid, that's not covered by insurance. That's a plastic or cosmetic operation, and it's elective, of course. So let's return to the step-by-step analysis of the lower eyelid. We talked about how people can come in and ask about the bags of the lower lid. That's typically, as I said, it's the fat that's lubricating and cushioning the globe, trying to push through the septum or pseudo-herniating against the septum and giving a very full prominence in the lower lid. Now, the upper lid can also have pseudo-herniated fat, even without extra skin. The upper lid itself can actually have quite a bit of redundant skin, especially as the brow comes down, and so the upper lid fullness can be because of the pseudo-herniated fat, and it can also be because of excess skin. But for today's discussion, we're going to talk mainly about the lower eyelid and improving that appearance. So, I start with the skin. Number one, is there excess skin, or is the skin there just have a lack of resilience? In other words, has it lost some of the youth and collagen layer and strength in it? So if that's the case, there are other procedures that we can do, such as if there's not too much skin there and it's just a sort of sun-exposed or deconditioned skin, we can sometimes improve the tone with a mini peel, a micro peel, a little medium depth peel, and sometimes laser. Now, as we look at the canthus or the canthal mechanism, if by testing the tone of the lower lid with something called a snap test, that's when I can physically examine, look at the position of the lower lid and feel the tone and examine the tone, we can actually go in and shore up. We can change the position of the lateral canthal mechanism or tendon by replacing it at a little bit higher position, or we can actually shorten it with a suture or other techniques. And that's called a canthoplasty. And that can help a great deal. So as I said, we've got to look at the skin. We can sometimes affect pigment in the skin. If there's excess pigment, we can treat someone with hydroquinone, different lasers, etc. We can affect the texture of the skin. For people who have excess muscular ridges in the orbicularis oculi, we can treat that with Botox, or we can sometimes go in and take a small conservative piece of the muscle, and that can decrease those excess ridges. We'll often see that. It looks like a somewhat exaggerated ridge right under the eyelash that people have in animation. That's an overactive or hyperacting orbicularis oculi muscle. Now, what we can do for the bags or the pseudoherniated fat is do an external approach. That's when we make an incision just under the eyelashes. That's typically if someone has a little bit of excess skin that we're going to remove. Or if someone does not have extra skin, I can do what's called a transconjunctival approach. A transconjunctival approach is a very effective procedure where I go to the inside of the lower lid. I guard the eyeball. I go to the inside of the lower lid so there's no scars on the outside. I slip in through the conjunctiva, through the lining, through what's called a capsulopalpebral fascia, and I get to those three pockets in the lower lid of pseudoherniated fat. I can actually shore up the septum, strengthen the membrane a little bit, and I can pluck out or carefully sculpt by removing selectively and rearranging the orbital fat. Sometimes if people have very deep grooves in what we call the tear trough, that's the junction between the cheek and the lower lid, I can use some of that extra fat to fill in that trough instead of a filler, say, or instead of doing fat grafting, I can do a little fat flap transposition to fill that in. Finally, before we do anything for the lower lid, we need to look at the cheek position. Sometimes the mid-face is affected by descent and affected by gravity, and that actually can pull down on the lower lid and give it a sort of falsely aging appearance, give it an appearance like there's a problem with the lower lid, where actually it's the cheek itself that's failing to provide support. Providing support to the lower lid is a lot like making sure that your house has a good foundation. We've got to have a good foundation underneath the house before we build on top of it. So again, in my practice, I think it's very important to do a very careful, individualized, custom surgical approach, and that starts with analysis. Thank you so very much. I appreciate you being here. This has been Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. I'm so glad you could join us. Thank you so much for being here.